A case control study was conducted to assess the relationship between alcohol consumption and breast cancer. First, the investigator interviewed patients with breast cancer. They then selected the neighbors of the patients with the sex, same age and race, and used as a control. Such a study design helps to control which of the following problems.
Waiting on you.
Is it observer's bias
Why?
or is it selection bias?
What? I'm not saying yes or not. You tell me why. Why do you think it's observer? Why do you think it's selection?
Observer bias actually that kind of bias where
Mm-hmm.
observer is observing something and that's why the outcome would be good, but it is not like that. Okay, it may be the confounder, like the uh, confounding confounder may be the problem. Confounder, like they are uh, putting somebody with interviewing somebody with breast cancer, but they are selecting the controls from the same age, race, and sex. They are using these people as a control. So there may or may not be relationship with this. Like in the confounding bias, initially we are thinking that a relationship, but in the long run there is no relation. So is it confounding?
It's confounding, but yeah, it's confounding. But I don't know if your explanation.
Matches.
I mean, yeah, I don't know if that okay, but it's confounding. But I think maybe you know what you're saying. Maybe it's the way you say it, but it's confounding. Okay,
Okay.
read the
Okay.
explanation.
So matching is efficient method to control confounding. It is frequently used as case control studies. The initial step involves the selection of matching variables, which would which should always be the potential confounders age, race. Case and the controls. Case and the controls are then selected based on matching variable such that both groups have similar distribution in accordance with the variable. In the scenario, neighborhood controls were matched to cases by age and race. Selecting neighbors as controls has another advantage of matching the cases to controls by variables that are difficult to measure socioeconomic status. So matching is the efficient method of the confounding.
Is that what you meant? What you were trying to explain?
Not really.
Oh, okay, okay. So yeah,
I, I,
matching.
I am thinking about the effect modification and the confounder bias. I'm thinking on
Confounding.
that way.
That's what I thought too, that you were trying to explain the difference between compounding and effect modification. Here they were just trying to tell you that because they did the matching, they made sure that both sides had the same age, race, live in the same place, whatever. So they use matching, so that eliminates the confounding. So matching eliminates confounding.
Okay,
Okay, yeah. Mm, so the
next.
answer is
E.
okay. Next, where are the answer choices? Okay, right here.
A study was conduct a study was conducted to assess the association between L-tryptophan use and the development of eosinophilia myalgia syndrome. Patients with EMS eosinophilia myalgia syndrome were asked about the use of products containing L-tryptophan during the last 6 months. At the same time, people without EMS eosinophilia myalgia syndrome were randomly selected from the same population where the patients came from and asked about their experience with L-tryptophan containing products within the last 6 months. The study showed that the use of L-tryptophan is significantly associated with the EMS. Which of the following measures of association are the investigators most likely to report?
Waiting on you.
Okay. Hmm. Is it median survival?
Okay, tell me what study design do you think they used? Is it cohort? Is it case control? Is it cross sectional? Is it chi-squared? Is it t-test? What do you think they use? Because I think you know what they're asking you, but what do you think they? Let's go step by step. What do you think they used?
Yeah.
Let me pull up
Sorry.
that table. So
Sorry. Is it like eosinophilia myalgia syndrome disease?
I pull
L-tryptophan.
out that tape, that no algorithm, so you can see it. Mm,
Patient is
okay.
not randomly assigned, isn't it? No. So then grouping strategy. Okay. Then patient with EMS like outcome are asked about the products of L-tryptophan during the last 6 months. Is it case control? Like outcome, then they are asking about the exposure. At the same time, without EMS, were randomly selected, ask their experience. It is case control, so it is odds ratio, exposure odds ratio, isn't it?
Okay. No, I don't know. You want me to pick exposure odds
Yes,
ratio?
yes, yes.
Okay. Let's see. You are right. It's exposure odds ratio. You see, instead of you just trying to blur an answer, just think about it a little. You already know the answer. Just think about it a little bit. Like go back to your algorithm. So far, this is the main algorithm that you kind of
Need
have to
to
memorize.
remember.
Yeah.
Yes.
To remember question. Okay. Can read the explanation.
The above case describes a typical case control study design. Patients with disease of interest cases, and people without the disease controls are asked about the previous exposure to the variable being studied L-tryptophan. The main measure of association is the exposure odds ratio, in which the exposure of people with the disease cases and is compared to the exposure those without the disease controls. And the option E, prevalence odds ratio, is calculated in cross-sectional studies to compare the prevalence of a disease between a population.
Okay, so I guess prevalence of ratio, just remember prevalence for cross-section. Okay, next. What is happening here?
Okay, CMR, crude,
I guess just read it.
sorry,
I guess just read it. I don't know. I don't think it's a question. I think it's just a statement. Just read
the
it.
CMR versus ASMR. People are earning money just doing ASMR. Okay, do you know what is ASMR?
No, what is it? I don't even remember this
It is,
slide.
uh, you want to see? It
What
just
is it? Uh-huh.
ASMR is just making sound which suits you, and they are doing like you are making a noise of a spoon and a tray. This
Mm-hmm.
this this sound can make you come, and that is ASMR.
This sound can make you come.
Not like a come, like people are doing this type of thing and they are earning plenty of views in the YouTube. Just write ASMR, you will find
Yeah,
plenty
I'm
of
gonna
views.
write. I don't understand what you like. Is it like sex related? Like
No,
sex?
no, 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 no. It's
Okay.
normal,
Oh,
normal.
okay.
Write,
Okay.
write, and see now.
Let
Then
me
you will
see.
understand.
ASMR.
ASMR eating, ASMR sleep. There are plenty of ASMR. Like ASMR. Okay, look here.
So she makes a sound, and then like the people that watch it, like if they
Yes,
feel
look at the video. 13 million. Just click it. That is ASMR.
but what is it? Like what like you're
The
supposed to like the noise?
Yeah, the sound.
Oh,
The only
you're
sound.
supposed to like the sound. Okay, okay,
Okay.
okay. That is crazy. I had never. Oh my god!
Is
And
it
it's a
worth
lot.
it? Is it worth it?
And it's
I
a lot of them.
Yes,
That's crazy.
look at the video. I- Okay,
Wow.
maybe we are crazy.
I mean, I had never heard about that. That's why I was saying, wait, what? But I'm thinking it's not the same ASMR as here, right?
Sorry.
As the
No, no, no.
oh, okay, okay, okay. It's not what the okay. Okay. What does this ASMR? Oh, it's here. Age standardized mortality rate. Okay, okay, got it. I was like, wait, is it the same ASMR that they are talking about here? Okay.
Okay. The cost specific crude mortality rate is the mortality rate from a specific cause, that is heart disease for a population. It is obtained by dividing the number of the deaths attributed to a specified cause. Sorry. It is obtained by dividing the number of the deaths attributed to a specific cause by the population size at the midpoint of a period of interest. The fraction is usually expressed by 100,000 population. A disadvantage of using crude rates to compare mortality between population is that crude rates are influenced by the underlying age Distribution of populations. The age standardized the age standardized mortality rate is a measure of mortality that eliminates the effect of the difference in the underlying age distribution of the population being compared. CMR, crude mortality rate, is affected by the age distribution of the population. ASMR is not affected by the age discrimination of the population being compared.
I think this is just a statement that you need to know. Does it make sense? One is affected by age, the
A
other one is.
not affected. A is not affected by the age ASMR, and CMR is affected by the age. Okay, let's see what we are getting. A physician working in a group practice that offers services to locations, location 1, location 2, conducted a study to estimate the crude cause specific mortality rate for heart disease at both service locations. The physician determined that the estimated crude mortality rate for heart disease at location 1 is half the estimated crude mortality rate on location 2. Additional analysis based on national data revealed no difference in the age standardized mortality rates for heart disease between service locations. Which of the following statement is consistent with the results of the study? Determine the estimated crude mortality rate. Crude mortality rate based on age. Location 1 is half. The estimated crude mortality. Is it option E?
E. Okay.
Yes, patients seeking services at location at younger age, because according to crude mortality rate for heart disease at location 1 is half the estimated crude mortality rate for location 2.
Okay. Okay. I think it's E too. Let's check. It's E. Okay, there is no explanation for that, so I guess you were supposed to. But you understand what is E? I know you know because you picked the right answer. You understand why it's E, right?
Even if I understand, you just explain whatever you are thinking. I'm trying to match what you are thinking.
Oh, okay. So they just said that the CMR is
It's
affected by
affected by
age
the
and the
age.
SMR. So
Okay.
here they're saying that when they use the CMR, they see a difference, but when they use the SMR, they don't see no difference. So it's definitely the age that is making a difference. So that we know that part. The age
Making a
is
difference.
yeah. And then they say that it's less people dying from heart disease in one and more people in two. So probably one has more young people and two has more like old people because we know old people die of heart disease more than young people. So that's why it's E. It makes sense a
Yes,
little bit.
yes,
Okay.
yes.
Okay.
Not little bit,
Next.
fully.
Fully. Okay. Good. Next.
In a selected study of bronchogenic cancer, it was found that in people smoking one pack per day one pack per day of cigarettes, uh, and the relative risk was 2.4. For those smoking two pack per day, the relative risk was 3. For those smoking 3 packs per day, the relative risk was 4.1. The corresponding p-value for these relative risks were all less than 0.05, with no overlap in the corresponding confidence interval. Which of the following statement is true regarding these findings? Okay, can you give me a second? An important call is coming.
Okay.
Okay, 1 second. Okay, question 4.
No, yeah. Oh,
In selected in selected study of oncogenic cancer, it was found that in people smoking a pack per day of cigarettes, the relative risk was 2.4. For those smoking 2 packs per day, the relative risk is 3. For smoking 3 pack per day, the relative risk was 4.1. The corresponding p-value for these relative risks were all less than 0.05, with no overlap in the corresponding confidence interval. Which of the following statement is true regarding these findings? Hmm. Okay, is it option 4?
which one? Sorry. Okay. So
D.
D. Okay, let's check. No, you tell me why you think it's option four.
Okay, smoking and bronchogenic cancer have a strong and a dose response relationship. Like 1 pack per day, the relative risk is actually increasing. The 2 pack, the relative risk is 3. So it is based on dose response relationship. Like smoking and bronchogenic cancer are related, have a strong association. This is normal, and it is based on dose response. Like the patient who are taking more cigarettes, they have chance of more getting bronchogenic cancer. Is that they are meaning?
Okay, I think I get what you're saying. And it's the right answer. I understand your explanation for the dose relationship.
Okay.
Yeah, you smoke one, you get two risk, 2%, whatever, two point
Yeah.
four risk. You smoke two, you get three. You smoke three, you get four. So I get it, but I don't understand why the strong association part. Uh, I think the strong association, you just said that it's a strong association because smoke and lung
Bronchogenic, yes, lung
cancer
cancer.
association. I don't think you should look at it like that because they may give you a question where there is no association and youth just think that yeah, smoking is associated with, we just assume. So you should look at the fact that they already gave you the p-value. So that means it's significant. That means that whatever you're looking here is significant, is true. So that's why the strong association is coming. I think you should, because what if they had given you a p-value of 10 here? Will
Yes.
D be the answer?
No, because p value
Right.
10, it is clinically insignificant.
Yeah. So that would mean there is no association between smoking and, but you know, in real life there is an association, but here
Yes.
it will mean like there is no association. So I think it's better to just go with what they are giving you instead of what what you know in real life. But you got it. You got the right answer. Okay, read the explanation.
Relative risk is used as a measure of association in cohort study. In the ratio, it is the ratio of risk in exposed group to that in the unexposed group, a relative risk more than one means that there is a positive association between the risk factor and the outcome. The relative risk less than one means that there is negative association between the risk factor and the outcome. The further uh, the value of RR from 1, the stronger the association. In the example, the RR of bronchogenic cancer in smokers is more than 2, thereby indicating a strong association between smoking risk factor exposure and the bronchogenic cancer outcome. When exposure is measured on a continuous scale, number of the packs per day, the classification in two or more ordinal categories enables the risk to be assessed as a function of exposure. The dose response effect can be calculated for the exposure and the outcome. This example illustrates a dose response relationship between the smoking and the bronchogenic cancer. That is, the relative risk for the bronchogenic cancer and increases as the number of the smoked of the PPD increases. Uh, okay. Know how to interpret the strength association and the dose response relationship for this study. Okay, next,
Mm-hmm.
Kaplan-Meier curve. A 68-year-old man with severe knee osteoarthritis comes to the office to discuss options for total knee arthroplasty. The patient wants to know which type of prosthesis will help him return to active style. A recent study compared the 10-year clinical, radiological, and survival outcomes of single radius prosthesis and multi-radius posterior stabilized prosthesis in TKA, total knee arthroplasty. In terms of clinical outcomes, the study reports that health survey scores were all significantly improved in both groups at the final follow-up visit, p-value less than 0.05 with no significant difference between two groups, p-value more than 0.05. The SR group has significantly less anterior knee pain and painless crepitation, p less than 0.05 compared to the MR group. Radiologic study in terms of radiolucent line and the component position angle showed no difference between groups, p more than 0.05. The Kaplan-Meier survival curve estimates at 10 years are shown below. Based on the finding of this study, which of the following conclusion is justified? There is a way of finding this Kaplan-Meier curve. I don't remember now. To see, I don't know the answer.
No, you know the answer. Pick one. Think about it. You don't need to know how to read this, the Mayan curve. Yes.
Okay, MR prosthesis should be recommended because its use resulted in better overall survival estimates. Yes, prosthesis. Prosthesis greater. Mm, I don't know actually.
Well, can you eliminate some?
Not really. My head is not working
Your head is
for
not what?
for
Okay,
this.
let's go one. Let's go one by one.
Okay.
MR prosthesis should be recommended because its use resulted in better overall survival estimates. Let's look at the
The
question. There's this. Oh, go ahead.
yes, yes, yes.
You want to say something? You wanted to say something?
No, no, no. You said
Oh, okay. If we look at the question, does it say somewhere that had better survival times the MR one? It says that both groups follow up were good. That's clinically significant, so they were good. And it says that there was no significant difference between the two groups. Well, that was false. It seems that there is some kind of difference, but it doesn't say what one. It says that the SR group has less anterior pain and crepitation. This is statistically significant. So the SR group is better than the MR group based on the knee pain and blah blah blah. It says that radiologic terms, blah, 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 showed no difference, but this is not statistically significant. If we look at the Mayer curve, I don't know how to read it too, but we know that there's the normal line, the one that's not dot, 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 the SR one, and the other one, they kind of both start at the same place. Okay, and this is
yes.
the survival rate. This is the years after operation. I mean, you can read it here. So they, and we are looking at 10-year postoperative, 10-year postoperative. Both of them at 10 year, it seems that the SR is high up. So I'm guessing the survival rate is, if we're looking from here, from 10
Yes.
year, it seems that the SR is high up. So I'm guessing that means it has higher survival. So from there, I think I would delete the A because here the A just states that the MR is better. But here we can see the SR is
SR is
better.
better.
And here from the explanation, we don't see anything, from the question, we don't see anything that says MR is better. So B, SR prosthesis should be recommended because it has a greater 10-year postoperative survival estimate. SR. I mean, here we saw that SR was higher, so maybe, yeah, I guess that can be an option. I guess let's keep it in our thing. Both prostheses had a satisfactory outcome, but the SR prosthesis should be recommended because it may be better for pain management. Remember what we read here. Both groups at the final follow-up visit score whatever. The study report that health survey scores were all significantly improved, so both groups were happy at the end, and this is statistically significant. So yeah, both groups were happy. But it says that the SR group had significantly less anterior pain compared to the MR group. So this is kind of true also.
Okay.
Okay, so we're keeping it. Either prosthesis can be recommended because there was no significant difference in outcomes between the two groups. It says no significant difference between the two groups, but this is false because the P is
More than
insignificant.
0.5.
Yeah, so this is false. So we can delete this one. And then E, neither prosthesis should be recommended because there was no significant difference between the outcomes in the two groups. We know that this is false. We see the 10 years of whatever, one is higher than the other. We see that here it says SR was had less anterior pain, and this is statistically significant. So there was definitely some kind of or some type of difference between the two groups. So we are left between B and C. Can you pick one?
It's B, I think so.
Okay, let's see if it's B. Oh my goodness, it was D. Well, time for you to read.
Okay. The Kaplan-Meier curve statistical method is used in cervical analysis to analyze time to event data, which refers to the time from entry into a study until an event of interest, onset of disease, death occurs. These methods takes into account that any potential event, that event of interest, loss to follow, the dropout, may occur at different points in time for different study participants. For this reason, the KM method compares the rate at which these events occur during the entire study period rather than at the end of the study only. The Kaplan-Meier curve depicts the probability of the survival at various time points during the study, calculated based on the proportion of the subjects who are alive or at risk for event of interest at different times. The X denotes time begin at begin the end of the study period. The Y denotes cumulative event-free survival rating from 1 to 100%. 100% patients have, sorry, where I am, okay. 100% patients have not experienced any event at the beginning of the study. As the study progresses, events occur and the proportion of the study at risk for an event of interest decreases, causing a downward dip in the curve. The KM method is also used to compare the survival curves starting from 1 to 100. 100% patients have not experienced any event at the beginning of the study. As the study progresses, events occur as the study, where I am,
I think you were here.
yes. The KM method is also used to compare the survival curves between two groups, comparing the two different treatment, comparing the treatment group to a control group, placebo group. The statistical test that compares KM survival analysis curve is the long rank test. A p-value less than significance level alpha, usually 0.05, indicates a significant difference in survival curves between two groups, unlike what is seen in the study group. P equal to 0.57, more than 0.05. The study reported improved healthy survey scores in both single radius prosthesis group and the multi-radius prosthesis group, but there were no di difference between the groups, P more than 0.05. It also showed no difference in radiologic results, P more than 0.05, or survival results at long-term follow-up. Long rank test, P more than 0.05 between the groups. Choice A and B. However, single radius processes were associated with less anterior knee pain than the multi-radius processes. P-value is less than 0.05. This means although both processes lead to satisfactory outcome, single radius processes resulting in less anterior knee pain compared to the multi-radius processes. Therefore, the single radius processes should be recommended because it may result in better pain management.
Sorry. The answer here is C. It's not D.
So
This is
they
a
made
mistake.
it wrong. Yes.
Yeah, it's a mistake. Because you can see it from the answer that they give there after you read the explanation.
Yes.
Yeah. Does it make sense?
Yes,
Okay.
you explain all the options, and it is fitted the two we have said, the B and C.
The B and C, yeah. Mm,
Okay.
okay. I didn't understand. The only thing I didn't understand was like, so the survival rate starts from here, and so this means that there is more people that survive here, or there is less people that survive here. That's the part I didn't understand when they explained the 100%. I've not experienced the y axis denotes cumulative event free starting from 100, so it starts from here and going down. And it says 100% of patients have not experienced any event at the beginning of the study. Okay, so as you go down, that means that they experience more adverse event. Is that what they mean?
Sorry.
For the KMS, as you go down these curves, that
Yes.
means that the patients are experiencing more adverse events. So here it will mean that SR patients have more adverse events than MR patients. Is that
Yes.
what they mean? Okay.
Probably.
Okay. Next, so you want to stop? Up to you. Let me know when you want to stop.
Okay. We will start from here. The question number 5 tomorrow. I
Okay.
think that it would be because everything is
It's
going away
blurry.
from